Next, I'd like to introduce Dr. Bobby Tay, professor of orthopedic surgery, one of the leaders in cervical spine surgery. He'll speak on single-level cervical disc disease, when to offer what.
Well, thank you so much, Sig. What a wonderful talk and a perspective on 20 years of great work. And it's interesting because we were fellows one time, and then we've gotten old, and all the things that we do, that we learn to do, aren't necessarily what we do now. But it's quite interesting how everybody has gotten more and more involved with, as time goes by, you become more of an administrator and less of a surgeon, I think. And look at all these things that I have to do. I'm this, vice chair of that, director of this, paying for that person. But what I really want to be is this. Director of single-level cervical disc disease. Because if I could just do this all my life, I'd be like a pig in right? I guess I can't say that, they'll bleep me out. So let's talk about single-level cervical disc disease because, everybody is an expert because everybody knows kind of how they like to do things. And for the most part, all their patients tend to do well. But it's interesting all the other things that you can do for patients within your spectrum of technical knowledge and surgical skill. So again, no relevant disclosures. 3 cases to start off with, each of them slightly different. First one's a 75-year-old gentleman, neck pain worse on the left side, radiates up into the left ear, mastoid area. Pain's been going on chronically for many, many years, has tried everything, has not worked out, and has this x-ray of a lot of spondylosis of the cervical spine. The only area that seems to be not totally affected is C2-3. Here's his cervical spine MRI showing developmental spinal stenosis, a little bit of C1, C2 stenosis, but what really is more dramatic is he's got unilateral foraminal stenosis, C2, C3, that on assessment with epidural injections, he did get improvement on. So that's one person. The next patient is a 49-year-old woman who had chronic neck and bilateral shoulder pain. It's gotten worse over the last 6 months. Also has symptoms of myelopathy, bilateral hand numbness, dropping things, gait instability. X-rays as such, 1-level disc degeneration, C5, C6, and on the MRI that's next, showing some multi-level disc degeneration with more bilateral foraminal stenosis, C5, C6. A little bit at C6, C7 as well. Third case, 54-year-old woman, right side neck pain, radiating to 2 radicular distributions, C6 and C7, with weakness, and got worse after chiropractic manipulation and did not seem to improve with physical therapy and other conservative measures. So 3 different patients, 3 different similar problems, and each of them, I can assure you, was treated slightly differently. This is her MRI showing the C5-6 level, some central stenosis, foraminal stenosis, and C6, C7, which has a little bit worse foraminal stenosis. So single-level degenerative disc disease, cervical disc disease, can have multiple clinical presentations, as you can see for the last 3 cases. Patients can have mechanical neck pain, radicular neck pain, which is often unilateral, full-fledged radiculopathy down a specific neural distribution, myelopathy, or a combination of any of the above. So what's causing it, right? So there's a lot of pain generators in the cervical spine, and we think about the disc as one pain generator. However, that's controversial. And we know that just disc degeneration alone, fusing patients for neck pain, is not often consistently good to treat their symptoms. For our non-operative or physiatrists and our anesthesia pain groups that do injections. Facet joint pain is often a common source of neck pain, occurring in about 54 to 67% of patients who have chronic neck pain. And we do have ways of treating it, although none of those treatments tend to be long-lasting. We generally hope that after a certain number of treatments that are non-surgical, then they may come to a steady state, but often, as we all know, the patients tend to come back with recurrent symptoms. And that's a trouble, and that's something that we don't know really what technologies there are to try to treat that, because there are not a lot of studies that says surgical treatment for this type of problem is effective. And then finally, there's the gold, and it's just like adolescent idiopathic scoliosis, cervical radiculopathy. And the incidence is about 1.1% worldwide. The best thing about it is that about almost everybody, about 90% of people, gets better without any treatment after about 3 to 6 months. So when do we do surgery? Pretty clearly, persistent symptoms despite about 3 months of conservative care or a progressive or severe neurologic deficit. What do? We have multiple options, and these are the anterior and posterior options. Anterior options include anterior cervical discectomy, a very traditional old approach that's without fusion. Fusion was then added on later on, and then plating was added on to the fusion later after that. And then with both anterior foraminotomies back in 1996 with Dr. Joe being the lead on that from Pittsburgh, and then finally cervical disc replacement. Posteriorly, we have one of the innovators, Dr. Fessler, who pioneered the posterior foraminotomy through a tubular approach. And then we have all forms of laminectomies and laminoplasties that we can do for a single level, interestingly enough, that I think we kind of lose faith on. We've kind of forgotten, mainly because the other operations that we do, like anterior-based operations, are so effective. But things to put in your armamentarium, for sure. The anterior approach is great for patients who have central herniation with stenosis, bilateral symptoms, patients who have radiculopathy and significant axial pain, and patients who've got a lot of spondylosis and myelopathy due to osteophytes that need to be removed around the spinal cord. Anterior options, we talked about, anterior cervical discectomy alone. And this is just for historical purposes, but I've actually, when I first started, one of our neurosurgeons at SFGH actually had an anterior cervical discectomy without fusion, and he was doing quite well. He had a little bit of focal kyphosis and some shouldery pain, but radicular pain was all resolved. So that was a very unique experience. Anterior cervical foraminotomy, first described by Dr. Joe in 1996, and that is something that I'm not familiar with, but I'm sure people in the audience are also familiar with. And the only downside is that you have to work fairly closely to the vertebral artery on that side of the pathology. And if you're comfortable with that, then it's a fairly good and effective approach. And then finally, cervical disc replacement and cervical fusion. I put those two together mainly because most of the studies that are best to assess our best way to assess the outcomes of cervical fusion were the disc replacement studies. Okay, so just for reference, this is Dr. Joe's original article on how to do an anterior cervical foraminotomy. He puts a little protector around the uncus and then drills the uncus down in part of the disc as well if you have a herniated disc. Since then, he and his children, actually Diana Joe and his son, have kind of moved that forward with endoscopic techniques, and that to them, they've had pretty good success rates. ACDF without plating, well, for one level, it works really great, but once you get past one level, the pseudoarthrosis rate starts to go up. This is a compilation of several articles showing the pseudoarthrosis rate and the difference between 1 and 2 level cervical fusion. So if you do a 1 level cervical fusion without plating, you can use both either allograft or autograft. You have to do good carpentry to make sure that the graft doesn't pop out. But you have about 97% fusion rate typically. If you go to 2 levels, the fusion rate drops to about 70% to 70 to 80%. So 1 level, you can actually do without a plate, and it'll save, like Sig says, it might save cost. But more than 1 level, probably worthwhile to put a plate on. So I put this slide in because it's a reminder that both the best information that we have about TDR, about fusions, is from what we know about TDRs. And this is an old slide. You can see the date of this picture, 2002. This was the first TDR, Pro-Disc C put in the world. This was down in Straubing, Germany. And I was there with Rudy Bertinoli, and we put that thing in on a patient who had 1 level disc herniation at C6, C7. And you can see from the picture, if you're all familiar with Pro-Disc Cs, the picture shows this gold tinge to the end plates. That was a titanium nitrile coating. That was the original design of this disc replacement. It had titanium and nitrile coating, which is a very, very low friction surface on polyethylene. And since then, we've had a plethora of different disc replacement types. They all work great. Really, they all work great. You just have to choose the right patient. And if you look at all these disc replacement types, everybody does well initially, and actually people do well in the long term. But you can see that from a fusion standpoint, fusions do well in the long term too, for 1 level disease. And the real separation starts to occur probably around 7 or 8 years after the index operation, where you start to see a little bit more secondary operations due to adjacent segment failure or disease. NDI is also increased. So the MOBI-C clinical trial was a very, very good one to talk about both 1 and 2 level disease arthroplasty in comparison to fusion. At over 10 years now, so now we probably now have about 20 years, but published about 10 years. And that particular trial showed significant improvements that last over time for 1 level TDRs and also for 1 level fusions. The reoperation rate for 1 level between TDRs and fusions are not significantly different, okay? When you get to 2 levels, it starts to separate significantly, but for 1 level, it doesn't seem to make a huge jump. And so if you bring that all together, going anteriorly for a single level cervical disc disease on the right patient with radiculopathy plus or minus some neck pain, you're going to get a great result no matter what you choose to do. You can choose to do a foraminotomy. You can choose to do a disc replacement. You can choose to do a fusion. People do very well initially, and that improvement continues to last over time. So why choose the posterior approach when the anterior approach is so good? Well, yeah, a lot of times you kind of say why, because we've got a great operation, right? So there are situations where a posterior approach is quite useful or advantageous, and most of the time it's because patients have very limited disease with very specific symptoms. And usually it's unilateral radiculopathy with mainly unilateral symptomatic foraminal stenosis. In addition to that, there are situations where anterior approach is very hard. Patients who had prior surgery, maybe radiation to the front of the neck, swallowing problems, big, huge, thick necks that you might have a hard time getting down there and exposing or localizing. Or levels at the junctional areas around C2-3 or C7-T1, which may not be accessible down below without splitting the sternum or shaving down the manubrium, or up high where you have to worry about the facial nerve and as well as significant swallowing problems. And also there's patient preference, depending upon what patients want to do with their lives. If you've got a patient who's a singer, professional singer, you probably don't want to go through the front of the neck unless you have a really good insurance policy, right? So let's go with the posterior foraminotomy options. Well, there's foraminotomies and there's laminectomies. The posterior foraminotomy is kind of what I really enjoy doing for patients who have unilateral foraminal stenosis or who has foraminal stenosis and unilateral discomfort. And there's a patient who's got that, right-sided, I believe this is probably by C5, C6. And you can do that both prone or supine. You can do that traditional open, mini open, which is a larger incision with a muscle split down onto the facet joint, or you can do it with a tube, with a camera. So we've done it all three ways. Prone positioning and sitting positioning, both are very useful. The sitting positioning is great because your x-rays are able to see all the way down to the cervical thoracic junction, even in fairly big people. So it's very consistent in terms of localization. And this is how I do a posterior foraminotomy. I think Dr. Fessler probably does it the same way, and Aaron probably does the same way. And I don't know, Lee, right? Yeah. Right? So you dilate down onto the facet on one side, you put a tube down, you put a camera in, and then you can see this. And the true value of this is improved visualization. And you have a smaller working angle because of the tube, but actually that's just enough. And there's two tube sizes, long and short, for thicker patients. And you just drill down the medial portion of the facet inferior articular process to get to the posterior articular process, superior articular process, and then you can see the nerve root, and you can press that, okay? So I don't think that video works. So how does it compare to disc replacements and fusions? Well, versus anterior cervical fusion, there was a nice article in JAMA Neurology just recently. It showed that posterior cervical foraminotomies do just as well as cervical fusions. The reoperation rate is slightly higher because some patients get recurrent discomfort. But in general, they do very well. And Dr. Fessler's article just recently showed that the complication rates are higher generally for cervical fusions and cervical disc replacements. And the reoperation rate, although it's a little bit higher, it's not a huge amount higher that would prevent you from choosing that as a first attempt at treating somebody with radiculopathy. And this is in comparison to the fusion, and complications as well as reoperations are generally less with the foraminotomy. And Sig talked about cost, and cost is going to be, obviously, it's currently a significant factor in what we choose, as long as the quality is there. So if the outcomes are the same, there's a nice study showing that the direct cost of a foraminotomy versus a fusion is probably about 3 times as much. And so in a good patient with the right indications, a posterior foraminotomy is both effective and cost effective, right? So can we do more than that from a posterior approach? I do not have any experience with this, but you can do posterior laminoplasties, and certainly you can do some interlaminar decompression centrally for one level without creating too much instability. So this is the posterior laminoplasty, and then, and I think laminectomies everybody knows how to do. So I put this in because I have no experience with this, but I think Rahul Shah just called me and says, I want to talk about D-tracts. So I put this in just for you, Rahul. I have no idea how this works, but apparently it does work on some patients. I just have no experience. And Rahul, you can talk to Rahul about that. So let's go back to the cases. This patient's got unilateral neck pain, goes up into his mastoid area into his ear. He got an injection, got better. He has foraminal stenosis at C2-3. We did a tubular, we did a tubular decompression on him, and that was literally about 15 years ago. I haven't seen him back for this problem. I've seen him back for his low back, but he's done well. His spine is all kind of auto-fused, right? So you'd expect that something you do would last him a fairly long time. So this is flex x-rays, no instability. This is the patient with chronic bilateral shoulder pain, neck pain, pretty much one-level disease. I did a TDR on him, And this was her preoperative and postoperative VS. So actually, it kind of helped the leg pain. I have no idea why, but neck pain and arm pain got better. So in patients who've got radicular pain as well as some axial neck pain, those patients actually do well with anterior surgery. And then the third case is an interesting one. 54-year-old, very active young lady who had neck pain and weakness, multiple distributions. And she's got this kind of two-level disease, right? So, Javedan, what would you do?
Probably a 2-level PDR.
I actually said, you got weakness. I'm not too comfortable with the TDR because you have weakness. You have a lot of spondylosis. I would do a 2-level fusion on you. She went nuts. She said, hell no, you ain't doing a 2-level fusion. I want a laminectomy. I go, shit, what am I gonna do? So I caved in. I did what the patient wanted. I did a 1-level interlaminar at C5-6, which was her tightest level, and I did 2-level foraminotomies at 5-6 and 6-7. She actually did really well. She had a lot of neck pain in the beginning, but actually after about 3 months recovered. She developed a little bit of left-sided triceps discomfort, but that went away after some physical therapy. And then she's dealing with other issues. But, these are just to tell you that what you choose is dependent on multiple factors. In addition, the main factor is what you're comfortable with, as well as what the patient wants and what are your goals and the patient's goals. And if they all are in alignment, anything that you do is probably going to work really great. So, Sig had a quote. I have a quote. I thought I wouldn't leave you without one. Just because we can doesn't mean we should. Just because we always have doesn't mean that we always have to do it. And once we know better, I think we can choose better. And that's the takeaway. Thank you very much.